this whole monoclonal antibodies came in, how the development happened, and what is there in the future. With that in mind, I tried to put it together. Let's go back a little bit about the history of immunology. This is Metchnikoff view of first, this is late 19th century or early 20th century. When they were finding, they do not know anything about cells, they realized about the phagocytic cells. These phagocytic cells, how they are phagocyting. So it is a representation. The cells and the neutrophils, etc., is an extension of their cell membrane. It's causing like a more, they call it as a side chains. And these side chains were released in the system and holding up the bacteria, and they're taking inside the bacteria or any pathogen and phagocyting, and then they're killing those bacteria. That was the principle. Later on, this is Ehrlich. Ehrlich, again, it is in the beginning of the 20th century. He postulated that most of these cells in the body, not only the immune cells, most of the cells, they extend these side chains to take the nutrition that is actually developed initially for the nutrition. This is the way they take the extension and catch the nutrition and the growth of the cells occurring like that. That is what he postulated. Then eventually he applied that to in the bacteriology or in the how the self-defense. So that you can see here the particles that are coming out, it's more of a cytoplasmic extensions of the phagocytes, and then releasing them, attaching them to the antigen or invading pathogen. And he called them as the side chains of the lymphocytes or phagocytes, and causing the defense of the body. Then there's some history we want to go through. It's again Mr. Bering or Dr. Bering and also Kitasato in 1890 first given the toxoids. Remember tetanus and diphtheria toxins, they were given to the animals. These toxoids, when they give the animals, they produce some serum particles. So they transfer that serum to other recipients, which can also develop in the protecting the infection. So they call them as the antitoxins or precipitants, agglutinins, reagents. These are the words that we used to by heart when I was in the medical school in 1975. And Paul Ehrlich came in, and first he named as an anticorpor for these particles that are developing in the body. So anticorpor, corpor means in Germany is a body. So it's an antibody. Again, there is a confusion whether this body is the one that is antibodies coming outside that is called as an antibody, or is it the body's response that is causing antibody. So they're all a little confused until 1907, where they clarified this body is an antigen. The antigen is coming from outside, is a body. So then Edelman and Dr. Porter, they awarded in 1972 the Nobel Prize for the finding the gamma globulins. They're early in the 1920s or 30s. A part of the globulin molecules in the chromatography seems to be as a separate that is working for these particular molecules in the immune system. Then they put it as a Greek word, Greek symbol, that gamma, and then gamma globulin. That coined the name of gamma globulin at that time. Then Dr. Hermans came in, make it as a immunoglobulins. That's by the time in 60s, the advancement of some immunology happened. This is a picture I just want to predict you that originally they're doing the serum. This is the commercialized first antibodies they're getting from the horses and donkeys, etc., and then giving the serum. If you remember, the serum sickness name came from him. The serum that is collected from these horses that were given the toxoids, which developed the antibodies, they took that serum and injecting to treat the various diseases, as at that time, especially diphtheria, etc. Sorry, somebody writing on the slides, please do not write on the slides, please. And then I want to go through the whole system, how it developed. This is actually the immunology. Don't think that the immunology of the birth to adolescence is not from the childbirth. This is called immunological birth to the adolescence. Initially, we had immunity. The immunity became into original thought about innate immunity, where the cellular, humoral immunity, and then the acquired immunity, humoral and cellular. When I was in the medical school, if I know there is a cellular immunity, humoral immunity, and humoral immunity is caused by the antibodies, and the cellular immunity is caused by the T cells, and innate immunity, they're all working together. That's a little bit later on, we notice in these antibodies are the major one that we were addressing it. It's always thinking about antibodies. Antibodies is the key role in defending the infections. So those are present there in the body. So whenever there is an antigen enter into the body, it attaches to the antigen and causes the immune complex and excretes. And also that will also sometimes activate on the complement, because these antibodies attach to the cells, the complement is activated, then they're killing the cell. That's a part of phagocytosis. And not only that, opsonization of the cell, of the bacteria, helps the phagocytes to engulf or to phagocytize them and killing the bacteria. So this was the initial stages. This happened until about in early or late 70s or early 80s. Then the cellular immunity, our cells were coming back, especially after the occurrence of the AIDS in the 80s. We noticed the cellular immunity has gained importance. And the cellular immunity, we know that the lymphocytes are getting killed. Since then, the research work and a lot of funding was siphoned into the understanding the T cells and the cellular immunity. Then we identified the two, B cells and T cells, and the T cells, again, they have how they're more specialized depending on the surface molecules of the T cells, selling about the CD4 or CD8, those kind of cells. It's separation of the T cells. And we were learning more and more about these T cells, which has led to formation of these monoclonal antibodies. Now, we are seeing a lot more of these newer drugs that are coming up. And the same thing, the interaction of the T cells and B cells is also, we understand and we elucidated in the last 30 years significantly better. And thereby we understand how the T cell instructions, the T cell communication, giving into the not only the B cells to the innate immunity, or cells that are causing the innate immunity. And now the future, we are looking into more of a checkpoint blockade. And this is the new concept. And the checkpoint blockade is like blocking an antigen before it works, or the cytokines it is going to work, or help the T cells. And once the function is finished, they're stopping the immune system. So these are the kinds that are in the future we're going to see. And then acquired immunity, we know that there is a B cells and T cells again divided depending on the cell surfaces. There are delta and gamma and alpha, beta. And in the alpha, beta, we now notice this is the AIDS. So since the AIDS came in, we understand the CD4 helper cells and CD8 suppressor cells. Again, in the CD4 helper cell, there are subclasses of Th1 and Th2. And now more and more T regulatory cells, and then T naive cells, how they're coming, how these cells are differentiating, we are learning more and more. Well, let's go back again in the immunoglobulin history. In Dr. Porter in 1962, he had the first model that was actually built up, was the immunoglobulins consistent with the heavy and light chains. And heavy chain isotopes for IgG, IgM, IgA, IgD, IgE, these are all invented in the early 70s, which is more of a, depending on how the heavy chain is coded, or how the heavy chain, type of the heavy chain that describes it. And we know now that IgG has a subclasses, IgG1 to IgG4. Even though we know that there are particles that are Benz-Jones proteins, which are Dr. Henry Benz-Jones in 1864 identified them as proteins present in the myelomatous patient cells. And these were later on found out that these are the light chains that are, we were called as a Henry, it's on his name as a Ben-Jones proteins. There are two types of Ben-Jones proteins. We all know the named as a kappa and lambda. So those become a light chain names, which is kappa chain and lambda chain. And then there is a fractionation happen in the late 60s and early 70s. The fractionation identified exactly what is the FC portion of the antibody, which we call as a crystallizable portion. And then the Fab portion. Fab portion is the other end where it's an antigen binding fragment. Then these molecules became more and more complicated. And we understand in the last 30, 40 years, the motifs, the molecular motifs, these are domains. Domains are like 100 amino acid length. It's including the strongly placed between with cysteine bonds and the disulfide bonds. These motifs are called as the domains. This systematic organization of these amino acids, anti-parallel beta-plated sheets, it's all, they were highly specified, arranged into the loops, which are very specific to each antigen. So then we do not understand why only 100 amino acids causing this kind of millions of motifs that's specific to various antigens. Then afterwards we find out that this whole domains, the whole immunoglobulin families are arranged by one or two genes. These genes, by folding it and cutting in between the genes, they're in combination, it is resulting in millions of proteins, immunoglobulins that can very specific to the antigens. Then we also noticed these kind of beta-plated sheets and the domains that are present in multiple other molecules, which are surface molecules. Then we call them whole thing as a immunoglobulin superfamily, which is that they also have a transmembrane or extracellular glycoproteins, which is domains that are similar kind of arrangements with the beta-plated sheets, as well as loops that are arranged functioning in immune system. This is a representation of an immunoglobulin. You can see here, heavy chain. So the crystallizable portion, FC portion, has two domains, which is constant H2 heavy chain. These are constant one. And again, in the Fab portion, it is called a antigen recognizing portion. This is highly specific. In that, there is again two domains. One is the constant chain, Hutch, and then the variable chain is in the distal portion. These variable chains are variable light chain and heavy chain. They both has specificity to attach to the specific antigen. That we understand now more of these complementary determining regions. I want you to really understand, because these regions are very, very important when you're recognizing the antigen, because this is where the highly specific antibody structure. This is where each antigen has specific structures and bonding that results in. So the variability of how they placed about these complementary determining regions gives the specificity to the particular antibody. And then now we're getting into the more monoclonal antibodies in the 70s. And Dr. Milstein, he's mainly working on the purification of the antibodies, crystallography and RNA sequencing, etc. So he was puzzled by the difference of each time when he's growing in the rabbit and serum, they're all entirely different molecules they're showing. So he theorized it is probably mutations that is happening in the rabbits every time when they're giving the each culture. So he gave a talk on immortalization of a rat myeloma with a mouse myeloma. This fusion resulted in a hybridoma producing types of myeloma immunoglobulins. But this has a two different one every time it is changing. So he presented a paper in one of the conference. So there is Dr. Keller, who was attending the conference, was excited and fascinated by this topic, and he wanted to go to and work with him for a postdoctoral fellow in Cambridge. So they both together worked on this, and it is his idea, Dr. Keller's idea, that instead of fusing two myeloma proteins like mouse and rat myeloma, he wanted to take a B cells from an immunized animal. That means it's a specific B cells. And at that time, he was doing with mainly, they're all working with the sheep red blood cells. If you remember the rosette formation and all in the early stages of immunology, we worked with a lot of sheep red blood cells when I was in the medical school. And taking an immortal myeloma. So there is a myeloma that take a mouse myeloma or rat myeloma, attach that the B cells, both these cells merged together and gave it become a single clone. So these cells are growing as a single clone, and repeatedly it is secreting the antibodies. That supernatant antibodies they have collected, since they are coming from one particular type of cell that produces from one immunoglobulin, it's called as a monoclonal antibody. So this is the beginning of the monoclonal antibodies. Then they have in the 80s, so they got together that human leukocyte differentiation antigen, which is they actually get together. They want to make it's become cytokines and molecules and the immunoglobulin superfamilies getting out of hand. So they want to get a reason for it. So they get together all the antibodies, all the markers that are available, and that's about 55 research groups that got together. And there is 139 antibodies provided by these different groups. So they made into, when they look into that, they have a lot of similarities in some of the groups. So they made into the groups of 11 groups and called them as a cluster of differentiation. So it's a group, each group is a cluster, and then they're differentiating from each other, they gave the numbers. So that's where the CD name came in. So when I was in a fellow, that's the time we heard about this whole thing released around CD 15 or so. And by the time I finished fellowship, this was rapidly growing. It became almost a CD 30, 32, and the interleukins were identifying. So these, right now, I think it's almost like 400 CD molecules that are named and available. And not only that, we are making it more names of subdivided into subcluster isoforms. I want to show here how we are, how the monoclonal antibodies were initially developed, and then we'll see the progression, how the progression came. This is a classic paper. Now, Dr. Milstein and Dr. Keller both together try to present in the Science in 1975. This is how to produce a monoclonal antibody. They took a cell culture, a myeloma line cell culture, and then they also immunized rats or mice to the antigen. So the antigen spleen cells, they took it, and then they merged the myeloma cells and the spleen cells with polyethylene glycol. That's a medium that helps our integrating to the myeloma cells. So if you look into that shade, so the pink and the blue cell together, those are more multiple, those are myeloma plus spleen cell, it's a hybridized cell line. Then they painfully take each one and try to separate the cells, each one, by serial dilutions. So you can imagine how painful it is to get a pool of it from separating. So eventually they were able to identify a specific one clone or one cell that resulting in only one type of antibody. And these antibodies, these clones that are these single clones of cells, they were injected into the peritoneum of the mice or rats, and then that produced a large amount of the monoclonal antibody. So this paper was published, tried to due to the nature, and they actually rebutted and refused to publish it. But by end of that year, they realized and then published as a letter to the editor. So what are the challenges that we face with the monoclonal antibodies? These are all the antibodies that initially is mouse antibodies, and then obtain these immunoglobulins, can we produce like this multiple? Again, it's if you are trying to produce this with a large scale, like what we are doing, we need now with this pandemic, it's almost impossible just working with the mice. So how to face this problem? And then they're avoiding the genoimmunization against mouse immunoglobulins. So how are we going to prevent? Because it's going to be a foreign protein, because the whole myeloma plus the antigen antibody producer cells both together, it's a foreign antibody. So it's going to cause any reactions? Improving the respective immune reactions initiated. So how are you this whatever the immune reaction that is developed or reacting, how can you improve that? How can you stop it and improve the pharmacokinetics of these drugs, so that how the drugs were given, whether taken orally, intravenously, IV, all these pharmacokinetics. These are the 3 or 4 of the problems that we are facing. So we try to address that with the mouse hybridomas. With the mouse hybridomas are the one mainly the animal hybridomas and the animal related antibodies. Okay, and then we try to chimerization. By chimerization, what we did is part of this immunoglobulin, the FC portion or of the heavy chain portion was changed into a humanized antibody. And then the light chains are the variable chain portions of it is still is more of a animal protein or animal antibodies. Then the phase technology came in. Phase technology, where we get a rapidity of that, we are increasing the speed of this, because this we can able to put the phase library and then take from the libraries and use them, separating the antibodies. So by that, the filtering, there's a large quantities of these antibodies were started developing. Later on, we developed the transgenic mouse. Transgenic mouse is nothing but the mouse that is genetically transferred, humanized their immune system. So by their genes were actually introduced and changed into humanized antibodies. So these cells, these mouse can produce, again, when you inject the myeloma proteins or the cells that were taken from that, resulting in the human monoclonal antibodies. Now it's more of PCR technology and the genetics modification. We are doing it actually producing the recombination of these antibodies. So the production of that is significantly improved. Now we can produce millions of these doses in a short time. It's just a slide that I put it now, how we went through from the beginning of from Behring's serum theory to the monoclonal antibodies, how they developed. And the first therapeutic monoclonal antibody was the OKT3. OKT3, it was named because it is Ardo is a company, and then Kung is the company owner. So his name, we took it as Ardo clone. So it's OKT3. It is a T cell receptor 3, that is actually T3 T cells antibodies against those particular receptors. So this is the initially caused a lot of side effects, so that we use it very, very carefully in those drugs. This is the drug that I was using, and I was in a working as an internal medicine resident for renal transplant rejection patients. And then in '86, that is grafted as a humanized monoclonal antibody, and then it became the phase libraries in '90s, and later on it is completely human monoclonal antibody with a transgenic human mice, which we talked about it. And later on, these phase libraries, everything, we were trying to glycosylating these the heavy chains. Therefore, some of the side effects we can be avoiding it. And now we have almost like 25 monoclonal antibodies. That's in 2009, but now I think we have almost 50 or 60 of monoclonal antibodies in clinical use, and there are more in the pipeline. This is the first FDA-approved monoclonal antibody, that Muromonab, which is CD23. It is a mouse antibody of anti-CD23 for prevention of transplant rejection. First therapeutic monoclonal antibody that was given in patients with multiple sclerosis. In multiple sclerosis, what is happening is these T cells are migrating into the brain cells and killing the brain tissue. And the monoclonal antibody was invented against an integrin that is present on the endothelial surface of the endothelial cells of the vascular cells. So when we're using this in natalizumab, which is an antibody against that, so the lymphocytes cannot attach because the counter adhesion molecule cannot attach the endothelial cell, so it will not cross the blood-brain barrier. Thereby, we are preventing the multiple sclerosis. This is the paper that was published in 1992. And what resulted there in these patients, few patients developed progressive multifocal leukoencephalopathy, which is a very lethal disease, and it's causing the demyelination of the tissue, which later on found that it's a viral infection. Because we are preventing these T cells entering into the brain tissue, there is no immunity of defending that particular virus. That virus is present in most of the humans, so that's why it resulted into the PML. Later on, the natalizumab was taken out of the market temporarily, and then when we addressed some of this problem, it is again in the market to treat the multiple sclerosis. Here, I want to show you how the antigenicity is coming from the page. Here, the murine antibody is actually, there is no human antibodies there. And when chimeric antibodies are called Zymabs. If you're wondering about the names, how these names came from each monoclonal antibody. So you can see here, if it is a purely murine antibody, it is called OMAB in the last, the end of the name that we added. And the chimeric antibodies are called Zymab, which is about 65% of the humanized. That means the heavy chains and are the mainly, the constant portion is humanized. Then we humanize at 90%, that is called Zumab. You see omalizumab, which is used for anti-IgE, that means it is still has bacterial or mouse variable chains, but the constant chain and part of the light chain, part of the variable chains also humanized. Then the recent one that's called is a fully humanized. These are called UMABs. And we will, so what I would like to mention here is by humanizing it to the 100%, then the immunogenicity is almost significantly, we're able to reduce it. And then now the monoclonal antibodies mainly are recognized as a human IgG1 antibodies. These were chosen targeted by their Fab portion. The Fab portion is the one that is specific to an antigen that we want to remove. Here, antigen means it can be a foreign body getting into the host, or it is an antibody that is developed in the host itself, can take it as an antigen. Or it can be some cytokines or some other molecules that are produced in the body will also act as an antigens. So the Fab portion is specific for that particular one. To give you an example, anti-IL-6 antibodies, which is where the Fab portion is specific to the anti-IL-6 cytokine. So the second one is the Fc portion. The Fc portion is the one that it attaches to the cells, different cells, and causes the immune reactions. So that's where, for example, if you have a bacteria, the bacteria was attached to the Fab portion. And then the Fc portion is attached to the different cells or phagocytes. Then the phagocytosis can happen. The same thing, it can release complements. So the complement binding in the complement dependent cytotoxicity that occurs due to the Fc portion. So once the complement activated, that will hydrolyze the protein molecule and that will kill the cell. This is also helpful in tumor immunology, where this Fc portion goes to the specific tumor cell, attach it, release the complement, and the tumor cell will go to death. And then attachment of these Fc receptors on phagocytes in antibody, it causes the phagocytosis, which can cause antibody-dependent cellular phagocytosis. attachment to natural killer cells. Those can cause us a antibody-dependent cellular cytotoxicity. So this is these are the three ways that actually these FC portions helps and how to defend the body from various injuries. And then these are mainly developed to against the lymphoma cells, against the tumor cells. That's where these monoclonal antibodies, by attaching the FC receptors, work. And then they took this FC portion and glycosylated. By glycosylating, this modulate the interaction and the impact of the drug pharmacokinetics. So how the drug stays in the system, how the drug enters into the cells, how the drug is eliminated in the system, or is it causing immune complex problem? Those we addressed by the main constant chain of the glycosylation of these particles. And then it changed not only the IgG1, we changed into the hybridization into the IgG2 into constant heavy portion, which bind that will avoid binding the complement. At the same time, it's also avoid the FC receptors. FC receptors are present on various cells. These are receptors where the constant chain of the FC portion attaches. There are different kind of affinities that are present in these cells. This is mainly used against antibodies that should not lead to the cytotoxicity. What it means is the FC portion will not attach to the FC receptor. So if it doesn't attach, it's not going to lyse it. But the antibody will work on that. Either it is working as to prevent the cytotoxic. That is what the problem in paroxysmal nocturnal hemoglobinemia, where the complement is activated and the cells will die. So here we are trying to stop that binding of these receptors with the FC portion so that we can prevent the paroxysmal nocturnal hemoglobinuria. And the removal of the FC4 fragment. So some of them we were able to remove that. So we are only using the antibody portion, so that Fab portions, which is first one is abciximab, which is a chimeric antibody against and GP2B and 3A Fab fragment. What it does is these two antibodies, this protein molecules, which is GP2B and 3A, this fragment is essential for platelet aggregation. So this platelet, we are developing these antibodies specifically come and attach to these protein molecules so that the platelets would not aggregate. So that was one of the drugs that we used. This is actually the second therapeutic drug that we used in the cardiovascular disease to prevent the platelet aggregation. Then immunoglobulins FC fragments used to produce chimeric drugs, combination with them soluble cytokine receptors. What does it mean, the chimeric drug? Chimeric drugs is the drugs or chemotherapeutic agents or other drugs that is attached to the cell. Actually, you take the FC fragment and attach it so that that cell, the FC fragment will go to the cell, deliver a target, specific target, give that whatever the action to be done. So the same thing, anti-TNF bioactives, which are now the rheumatoid arthritis, infliximab, and those things are mainly the anti-TNF bioactives that we can use and control the inflammatory diseases. It's not only inflammatory diseases, in many of the chemotherapy drugs are delivered like with this, and so that we can have a targeted chemotherapy so that the side effects of the chemotherapy is a minimum and it is killing mainly the disease itself. And it also increases by adding the half-life of the recombinant proteins, which is by attaching to the EPO, erythropoietin, and coagulation factors. You know how these are highly labile, so that we can increase the half-life of the recombinant proteins, so we can use therapeutically in patients. So other therapeutic uses of the monoclonal antibodies are many of them are hemato-oncological disorders. We're seeing a lot of chemotherapy drugs, and not only that, these are the nude molecules. What is the nude molecules? That means these antibodies do not attach with any the chemotherapy drugs or any other modifiers. They directly go and act on the cells. And then the magic bullets, which we talk about it, where these vectorizing the drugs. That means it takes a drug on Fab portion and the FC portion go and attach the specific receptors. Or you can attach the drug to the FC portion and send it the antibodies specific to those tumor antigens. This is where the tumor antigens are very useful for us. So many of the chemotherapy drugs come in, and many of the cancers we're able to treat by attaching these chemotherapy drugs or toxic drugs that are supposed to be toxic to the most of the cell, that can directly, like a magic bullet, get into the cell, and so that it can kill the tumor cell. Mainly use the solid tumors like hemophilia and other, we just talked about it. And another part is the asthma and other allergic disorders. You probably noticed many of the drugs that are recently releasing were the asthma and allergic drugs that are effective in controlling the inflammation in the asthma. We not only that, we are seeing many metabolic disorders we're trying to treat with hypercholesterolemia, and then the macular degeneration, other inflammatory diseases like Crohn's disease, then other GI tract ulcerative colitis, etc. Diabetes mellitus, which is a metabolic disease, which we are also trying to address the specific pathways with monoclonal antibodies. I want to go a couple of slides just to understand. This is the allergy immunology, mainly in the allergy division. We're using the anti-IL-5 and IgE antibodies. This is an antibody that's benralizumab and the rituximab. These are the two antibodies that we use. Benralizumab attaches the anti-IL-5 receptors, and the rituximab and mepolizumab attached to the it's attached to actually IL-5. So whether you are addressing the specific antibody in the free form or addressing the receptor where these cytokines are coming and attaching, that will help to understand and approve work for the disease. So these are antibodies that are effective in controlling the eosinophil migration and eosinophilic growth factors. So by decreasing these eosinophilic growth factors and eosinophil migration, we can control eosinophilic asthma significantly better than when we're using the broad spectrum anti-inflammatory drugs like inhaled steroids, etc. Also, we're developing the JAK inhibitors, where by addressing that modification, which is helping to decrease the inflammatory cells or inflammatory cell action. This is another monoclonal antibody, which is dupilumab. Dupilumab is an anti-IL-4, anti-IL-3 antibodies. So when you are using this one is attached specifically to those interleukins, so that they will not act on the cell surface molecules where there are receptors, so that by preventing the growth of the eosinophils. And as like anybody else, we are seeing with any other drug, we're seeing the side effects to the monoclonal antibodies. That initially we saw acute infusion reactions, that like anaphylactic reactions, anaphylactoid reactions. The difference between the anaphylactic reaction and anaphylactoid reaction, anaphylaxis is actually developing IgE antibodies against these drugs, and the body will react by releasing the histamine chemicals from the mast cells, causing the anaphylactic reaction. Anaphylactoid reaction is nothing but the same anaphylactic reaction type of reaction, but there is no IgEs involved. So there, the cells do not have the IgE antibodies against the antibodies that we're introducing. So the IgE antibodies mainly produced when we're giving the mouse antibodies or ZMABs, but when it is humanized, the anaphylactic reactions became very less, unless very rarely occur. Anaphylactoid reactions, in another sense, what it does is when there is two IgE receptors on the mast cells are bridged without IgE, that releases the mast cell various chemicals, including the cytokines as well as leukotrienes and histamines. So that causes anaphylactoid reactions. So the classic example is vancomycin-Redmond syndrome and other drug reactions like radiocontrast medium reaction. So there is no IgE antibodies. These monoclonal antibodies, when we're giving it, they're going there, actually bridging to IgE receptors, resulting in anaphylactoid reaction. Serum sickness occurs with immune complexes because, again, there is an antibody and we are using against antibodies, which can cause immune complex formation, which result in the serum sickness. Tumor lysis syndrome is another one, which is a very serious problem. When we're giving antibodies, actually, there are massive amount of these tumors dead when they're dying, that resulting in a lot of cytokine release, and then it causes cytokine storm, which probably you all hear of the cytokine storm with this pandemic. And monoclonal antibody against necrosis factor alpha, that is TNF alpha, associated with the reactivation of latent tuberculosis. That's why whenever we doing the infliximab, which is a TNF alpha antibody, whenever we are giving this infliximab, we test them for the tuberculosis. We just them to the TB test, and if it's negative, then if it's not negative, we usually prefer the other drugs. They can also cause other serious infections and malignancies. One of the example is anti-L6, which resulted in significant amount of systemic the infections. Progressive multifocal leukoencephalopathy, which we talked about it, which happened with the neutolizumab, which is used in mainly multiple sclerosis, and then the other drugs that resulted in the rituximab and eculizumab. Treatment with abciximab. It's an antiplatelet glycoprotein, which we talked about it. It causes the thrombocytopenia. It may result in immune response, that autoimmune thrombocytopenia occur with these monoclonal antibodies. So one should be careful about those things to keep in mind. Anytime when you're using these antibodies, the autoimmunity can develop and result into eventually the autoimmune problems. Monoclonal antibody directed against TNF alpha also causes lupus-like syndrome, which we talked about it, by forming the immune complexes, which is also causing attaching to various tissues like a thyroid, which can cause an autoimmune thyroiditis, autoimmune colitis, etc. Monoclonal antibody against a human epidermal growth factor. It's caused in the skin rashes, extensive skin rashes, and also it can also cause cardiotoxicity. That's depending on the specific factor that we're attaching. Cytokine storm seen after infusion, which we discussed, and especially everybody knows about the cytokine storm, which is resulting in a large amount of these cytokines, multiple cytokines that are result. It happened originally because we directed actual T cell receptors, which causes the stimulation of the T cell receptor CD8 and causes the multiple amount of the lymphocytes developing and releasing into the chemicals. I want to talk about it a little bit more now in the future. What is the future in the monoclonal antibodies? As you all know, that mouse is the first generation is the mouse antibodies. Then we have the chimerization, and then we're seeing the part of it is a humanized, depending on how much is in the humanized IgG that causes the allergic reactions. Then the next one is we went into the more of a humanized monoclonal antibody. It's 100% humanized. But now we are thinking of more. Remember, there are two light chains. So we are attaching one antibody, two different antibodies for both the light chain. That is what we call a bispecific monoclonal antibody. So these are distant antigen that is attached. Now, how it works, we're seeing in that. And not only that, we are seeing the small fragments, the small antibody fragments, just to take the light chain receptors, light chain variable portions. That's where you're seeing in the F, here is a monovalent single chain variable fragment that just took off the small particles and using them to attach to the drugs or to remove certain kind of antibodies or antigens from the body. And at the same time, just like we are doing the bispecific monoclonal antibody, you also develop the bivalent variable chain antibodies. The action of the bispecific antibody. Why are we using this one? So this is a very interesting concept where we are taking the tumor cell, where the tumor cells has a specific tumor antigen. And then that is one of the antibody that portion, that light chain is attached to the tumor antigen. And then you take the T cells, which is a CD3. T cells, are essential for resulting in all these cytokines, which are against tumor cells. So you attach the T cell. So you brought these two cells together. Then the cytokines that are produced by the T cell directly act on the tumor cells rather than wasting in the medium. And also the Fc portion is attached to the innate cells like NK cells, macrophages, other cells that are destroying the tumor cell. So here what we're doing is the Fc portion that can attach to the accessory cell. And then the CD3 portion of T cell is attached to one of the antibody portion. And then the tumor antigen specific, depending on which tumor you want to treat it, that tumor specific antigen to attach. So what it does is it takes this T cell and the macrophages close to the tumor antigen and combine. So when they're together, the cell destruction of the tumor is very targeted, and you can clear it up wherever this cell is hiding. These antibodies take the cells there and attach them and kill them. So the amount of the drug that we are using can be minimized, and the side effects of the drugs also can be minimized. This is a big science that we are, it is developing now, where I want to show you in a sequence how these things are working in a monoclonal antibody. Just we talked about the bispecific monoclonal antibodies, or bispecific variable portion, or the Fab portion monoclonal antibodies. Also the quadroma means it has a multiple, like you saw the other antibody, they have Fc portion different, and the other antibodies, there are 3 or 4 antibodies attached, which specific to different antigens. So they bring together the chemicals or the cells so that they can achieve optimal the effect of these cells and the drugs to achieve whatever the thing that we would like to do. So, and now we are seeing more and more fragments, like the single chain variable fragment. It's called SEFE, or it is a bispecific dibody. That means it has the same thing, 2 different dibodies. And then there is a single chain specific dibody, then single chain bispecific tandem variable domain. These are all the antibodies we are now, so that the reactions will be less and we can produce more of these drugs. And recently, the latest one that I'm talking about is bispecific single domain antibodies. So that specifically address the issue, what we want to do. This is the future of the immunology now. Now we were entering into the chimeric antigen receptor T cells. It's called CAR T cells. What is happening here is we are taking a specific receptors. We are taking a specific receptors which that stimuli as a signals. So you can see that signal 1, or there are multiple signals we can introduce. These receptors are introduced into the cell. And then there is another antibodies, or the antibody motif, that is, are the biphasic or single phasic motifs that are attached to the signals. So this is a transmembrane, the whole synthetic material that enters into the signals into the cell, and then antigen recognition domain is outside. So we can now change these signals if we add the multiple signals, which result the co-stimulatory effect. These stimulate, and whenever there's an antigen, specific antigen attached to the antibody or the antigen recognition domain, it will give the signals to the cell. So cell will produce whatever the chemicals that is trying. Or these T cells are very effective in specific cell, addressing and killing the specific tumor cells. This signal of the cell from the surface receptor to the giving to the motive to the cell, which will result in these T cells really effective. So we can transfer these T cells. This is actually done, taken of the T cells from the patient so that they will not get any allergic reaction. These T cells we reintroduce by attaching those signal modifiers as well as the antigen recognition domain. So these T cells itself work as, with the help of these monoclonal antibodies, goes to the tissue and address the issue. Not only that, These T cells, again, remember, these are all the memory T cells, they stay in the system. So these T cells will live with the human being or with the host forever. And whenever there is a same antigen containing tumor cells produced, this will reactivate and works like a, again, booster dose, and immediately they kill. So it's look like a not only just one-time treatment, treatment is going to be there for the whole life of the human or the host. This one I would like to just address about this foundation of immunology was initial people. These are the initial people that were diagnosed about the phagocytosis, initial complementation, and the innate system, etc. And then lead into the antibodies and B lymphocytes. These are all the scientists that worked on this one to give you an idea. And then these are the more of a recent development in the T cell function. These are all the scientists. And now we are growing into the further more in the immunology to address more specificity and more targeted treatments. And then I just want to conclude with a slide, and it would be an amazing scenario to see those earlier scientists like Metchnikoff, Ehrlich, and if we can bring them back and show them now our world and see what happened following their initial discoveries. And it will be, they were right and telling them about the many points of their observations. And certainly it paved the way for others daring and imaginative researchers to follow their path. And it would probably be even more puzzling to show pioneers of vaccination. If you remember the Jenner and Foster, those people, if they come and see these molecular intricacies and beautiful mechanics underlying their intuition, that the exquisite specificity of the immune system can be manipulated for the benefit of the health. With this, I will conclude my talk, and I'll be happy to answer that questions that I. Again, thanks, Dr. Sudhakar, for giving me this opportunity.
Yeah. Thank you very much, Dr. Suresh, for a very elaborate presentation, and making all the students and the postgraduates understand the details of the immunology and the origin of monoclonal antibodies and their therapeutic value. If there are any questions, I wish to invite the floor to get them clarified from you. Before that, I just want to have one or two questions. One is, like we know that this has to be given, monoclonal antibodies against the COVID-19 have to be given in the first week of the disease. That's what we were told during our discussions at various times. How extensively are these being prepared, and how they will be made available to the public? Or we all know that the Donald Trump had taken these. So is it available for the common public, in the sense the patients of these widely? If not, what are the limitations?
And for the current pandemic, these two are the excellent questions and the doubts and how to use. I think in my few previous discussions also, we talked about these monoclonal antibodies, and many of the colleagues that are in Vizag know my opinion about earlier the use of anti-IL-6, anti-IL-1, and JAK inhibitors. See, these are all the antibodies that are developed against the different monoclonal antibodies. And then now we are in a stage that we are developing the monoclonal antibodies against the protein molecules of the virus. Okay. So what we are doing is, by blocking these protein molecules, for giving you an example, which is called blanlanivimab, which is a very difficult name to spell, okay, which is an antibody against the spike protein. So this is monoclonal antibody developed for against the spike protein. So what it does, when you give this antibody, it will prevent the spike protein to attach the receptor. Okay. So what we need is we need these antibodies, and also some of these antibodies were developed against the receptors on the cell surface. The receptors we know, this is ACE2, which and antibodies against ACE2. So that will block this and the virus to enter into the cell so that it will not multiply. So most of these antibodies, if you are giving in a very early stages, like first 5 days or 7 days, actually it will work. It does decrease the viral load significantly. So that might affect in many patients. But unfortunately, if you remember, and I know Dr. Prem Kumar, we had many discussions in the past, is the virus is not the problem in this disease. The virus is entering into the cell. Once it is entering cell, it's almost 3 days by the time you realize the symptoms. Since you're realizing the symptoms after 3 days, it is already triggering the mechanism of inflammation in some people. So even the benlilimab, highly specific antibody that was given to prevent the entry of the cell, because it's already the virus is there, it helped to decrease the symptomatology that patients are, those who are not hypoxemic, but it did not prevent the death rate. So it is not helpful to control the death rate, but it helped to prevent them to get into the admission into the hospital, because that most of the people, the viral load, depending on the symptoms, fever and all, it controlled. Hypoxemia has controlled many people. So that helped. So we were able to prevent significant admissions in the hospital by using this monoclonal antibody earlier in the course. The same thing happening with the antibodies of the cocktail that Trump received. It is instead of against one protein, they use 2 or 3 proteins. Probably one is a receptor. I still did not have the data yet. They did not release the complete data of this. What is this cocktail contain? So it is the same principle. It will stop the further viral entry into the new cells, and the multiple growth might stop. But it did not prevent the death rate. So the studies did not show any improvement in the mortality of these patients, because the cells already, some of the cells infected, they already triggered the immune mechanism. But the same principle, we are using the antibodies against IL-6 or IL-1. They're not helpful because we're only addressing one particular cytokine. That's why we're not able to prevent the mortality. On the top of it, if you remember, the IL-6 has a dual role. It's not only pro-inflammatory, it is also an anti-inflammatory. So we are addressing that completely stopping the pro-inflammatory. That's why we're seeing a lot more infections in patients. Okay, so the monoclonal antibodies in this viral condition was able to decrease the severity of the disease in many people, but those who develop into the cytokine storm, whatever that we're talking about, hyperinflammation, were not able to prevent the mortality. And the question that you asked, how much it is available, and what I was told is this cocktail that Trump received, they can be available about 300,000 doses by end of March. That is almost a drop in the ocean. We are using the benlilimab, which is almost available in all the hospitals here, to give them as soon as the patient come to the ER, and we treat them. And usually we are discharging the patients with that, and unless their hypoxemic get worse, they can come back. So the same principle that we are using the monoclonal antibodies, the antiviral medications. Yes, they do help when you use in the early stage. But the problem with this disease, especially with this pandemic, is how can we identify these patients very early? Yes, we can use probably on the contacts if they're finding without any symptoms in the early courses. But once the disease happens, it's not changing the mortality.
Thank you very much. And Murthy is there, who there is he wants to speak something. And Murthy, please go ahead and speak.
Yeah, good evening. Am I audible, Dr. Sudhakar?
Yes, you are.
Yeah, good evening. My name is Brigadier Murthy. Suresh, నేను పద్మనాభమూర్తిని మాట్లాడుతున్నాను.
Hello. Good evening, Brigadier Sir. Yes, hey,
Good evening.
long
Good
time.
evening. Yeah, it's been a long time. Nice seeing you on the screen. I would like to ask you, I would like to share my experiences with tocilizumab. I have treated about 6,000 cases in a district level 1 hospital at Rajahmundry. My experience with tocilizumab was absolutely unsatisfactory as far as the monoclonal antibody is concerned in the COVID. And in a few cases, we have a limited exposure to tocilizumab. The experience tells us that after the first dose, because the patient wasn't doing well, we went for the second dose also. And to our horror, the IL-6 levels have gone up by 1,000 times. Initially, it was around 100 or something. And after the first and second doses of tocilizumab, my IL-6 has gone into a whopping number of 5,000 plus. We got it repeated twice, thinking that it must be a lab error. We lost the patient. Number one, that is, how do we explain that? It is supposed to be an anti-IL-6, number one. Number two is, we have found that there is a different approach in the outcome of outcome of the IL-6 when we give conventional route of administration as compared to a subcutaneous administration of tocilizumab. So that's what I thought I'll share with you, and if you have something to add on, it'll be nice. Thank you.
Yeah, thank you. Nice seeing you, Padmamurthy. And exactly, I had, Dr. Prem Kumar can also tell us. I'm completely against of using the IL-6 antibodies. Okay, that's being no study has shown that anti-IL-6 monoclonal antibodies has changed any mortality. In fact, there are studies that shown it increased the mortality by increasing the infections in the body. I want to explain a little bit about that, which you can understand about what the two problems that you have and what you saw. IL-6 is a cytokine that is responsible for some of the T cell growth. It's not only responsible for T cell growth, it is also an antibody that helps to produce inflammatory cytokines. That means these cytokines and other cytokines that are produced that effectively prevent the infection that progress. So it is also an anti-inflammatory drug. How the difference is, IL-6 occurs in two ways. One is surface bound, that is bounded to the lymphocytes, and IL-6 comes in the free form. And the IL-6 that comes in the bound form is the one that works for an anti-inflammatory effect. And the IL-6 that are free form is mainly, sorry, the other way around. IL-6 bound form is the inflammatory effect. That's what works on to prevent you getting the infection. And the free form is the one that causes the opposite effect. So what you're doing is, when you're giving anti-IL-6 antibodies, that is, it is just attaching to the free form. So the bound forms are not effective. There is bound form. So what happens in these patients when you're removing the free form, actually the lymphocytes start producing more too. So what it does is it produces more and more release into the system. So when you give the antibody, it takes out the free form, and then the lymphocytes are producing more and more. You cannot prevent it. So that's probably one explains that in your patient, when there is IL-6 levels went up after treating with the anti-IL-6 antibodies. And the second thing, as I mentioned, because it is a double-edged sword, when you are treating it, you are preventing the actual clearance of the other bacteria. So as you know, in most of our ICUs in the hospitals, that we're prone to develop all these iatrogenic infections. That is what causing more of an infection and death in the people that are admitted in the hospital. This is the antibody that we usually give in the hospital, right? So that's why the anti-IL-6 was never proven. Same principle, the anti-IL-1 did not proven to be effective. So I hope that answered your dilemma and what happened in your patients.
And Dr.
Okay,
Suresh,
thank you,
permit
Suresh.
me,
Yeah.
I can talk a few minutes.
Prem, you pitch in. Mohan Maharaj has put it in the chat box saying that we are not supposed to check for these IL-6 levels once the drug is given. Can Mohan Maharaj comment on that? Mohan.
Sir, normally, thank you, sir. Whenever we are doing IL-6, normally as anti-IL-6 medication we are giving, it is previously they used to think if it is less than 50 or around, say it's infection more than, because sepsis, surviving sepsis guidelines and other sepsis also, it goes more than 450 and 500. If it goes more than 10 times, definitely it is inflammatory or infection. So we have to rule out the infection first before giving tocilizumab. Out of more than 2,500 above patients we treated, we have given only for 2 patients. Only if you say that procalcitonin and CRP are normal and still IL-6 has been more than 450. So that was what we are telling. But once we give the medication of tocilizumab, and definitely your IL-6 is going to be more than 2,000 or 2,000 above. So that reaction, as sir explained, Suresh and sir actually clearly explained very well why it comes high. Thank you, sir. That's why we are not supposed to check the IL-6 levels after giving medicine. Thank you, sir.
I totally agree with you, Dr. Maharaj. See, the IL-6 measurement, we do not do it. As an ambulatory care patient, I have not done an IL-6 measurement in the last 9 months, not even a single patient. When they come in the IL-6 measurements, I tell them, don't worry about it. So it doesn't help us any treatment. Initially, we were excited. We were excited that it might help. But after the first 2 weeks, I saw in the patients in ICU dying with the infections, we stopped it.
Yeah, Prem Kumar, please go.
Actually, this tocilizumab is an IL-6 receptor blocker. So this tocilizumab blocks the receptors. So the IL-6, free IL-6, which is unable to bind to the receptor, the levels will increase. So it is obvious that once you use tocilizumab, the IL-6 levels will increase. That's why we never repeat the IL-6 levels. And IL-6 will increase in any inflammatory condition. Even in pneumonias also, IL-6 will increase by hundreds. So don't bother about that. And as he said, the efficacy of IL-6, the Covacta trial or Impacta trial, so many trials are there, and they discounted the tocilizumab's use, and it is also an immunosuppressant. It reactivates tuberculosis and the secondary bacterial sepsis and even fungal infections. We have seen so many cases of ocular and systemic mucormycosis after using this tocilizumab. So basically, the tocilizumab is the receptor blocker. It blocks the receptors. That's why IL-6 levels obviously increase after its use.
Yeah. Okay. Naveen is there online. Naveen wants to say something. Naveen. Naveen.
We're not hearing you, sir.
Yeah. Naveen, go ahead.
Naveen, unmute yourself, Naveen.
Yes.
Yeah.
Thank you, Principal Sir. First, it's an acknowledgement to Anna Suresh Sir for these 2 lectures and participating in all the lectures, and also for his wonderful donation to Chest Hospital for the big digital X-ray. Sir, Dr. Moti Ramgopal of Florida gave a lecture on this future therapeutics of COVID-19. Particularly about this monoclonal antibodies, sir, last month to the physicians forum of Visakhapatnam. It was almost on the similar lines, sir, like what you said. He was endorsing all the things that you were addressing, sir, Suresh, sir. And one more, digressing from this thing, sir. Today I got a call from one of my patient healthcare workers, sir, about the vaccination, sir. She's an asthmatic patient. What we are giving is Oxford Covishield, sir, today. She was apprehensive about taking this vaccine, sir. Anyone can answer this question, sir.
I'm not worried about any of these. All the vaccines are pretty safe only. The only thing that we will be addressing is patients who have a demyelinating disorders, because there is a potential developing the demyelination, which we also call as a GB syndrome or Guillain-Barré syndrome. And some patients develop after taking the vaccines, especially in the influenza vaccine. As you know, many of our the physicians that treated the COVID-19 infection patients, they do have about almost look like 1% of patients developing Guillain-Barré syndrome or other neurological demyelinating syndrome, post-COVID syndrome. So it is not specific to the vaccines. Probably the vaccine protein developing antibodies that are causing the demyelination, or the T cells that are activated that are causing the demyelination. So even if you don't take the vaccine, still there is a chance of, if you get the COVID, there's a chance of getting the demyelinating disease, but that can be treatable. And especially with this stage, we have a good drugs to treat it. And second thing is, if the patient has a previous history of Guillain-Barré syndrome, we try not to give them. That's at this time we're making it as an absolute contraindication. Other than that, the other thing that came in is this PEG. Remember the polyethylene glycol reaction? That's what was noted in British literature with the Moderna, which is an mRNA vaccine. That is used that has a little bit of issue. But in US, we are given right now the millions of doses. We have only one anaphylactic reaction occur in Alaska that needed really an ICU treatment after the vaccine. Other than that, we have not seen major reactions. Most of the other ones are local reactions or mild fevers lasting for 1 or 2 days. Now we are doing the second dose immunization. Right now, in the last week, started the second dose. We want to see whether there is any effect on that. But on the whole, all the vaccines are safe. I don't see any. Only difference between these vaccines is the potency. Which one is effective? About 94%, 95%, 80%. That's the only difference.
So wasn't there an alert in UK about for asthmatic patients or any patients with allergic disorders early on, sir, when they started in London?
As there is an alert, that's an alert was mainly, now we think that the PEG alert, that is a polyethylene glycol contamination, or some other contaminants are the preservatives that they're using probably. But in US, they said if anybody has an allergic reaction, we want them to stay in the site at least a half an hour. So any allergic reaction occurs, because these are all given in the hospital with the healthcare people available, then that can be addressed. And I will also add this here for Dr. Sudhakar and the physicians that are involved in vaccination. If you can find out to see whether you can get evaluation of these patients with serum tryptase levels. Serum tryptase is a definitive marker for the anaphylactic reactions that will help to see whether these are truly anaphylactic reactions, or these are vasovagal reactions, or these are the hysterical attacks, and all those things that we can easily differentiate it.
Thank you, Suresh, sir. Thank you, Principal, sir, for the opportunity.
Thank you. Dr. Buchiraju, would you like to say something?
Yeah, it's Dr. Anna, it's a good review. As a neurologist, I have more of a general question. We have maps in every condition other than like multiple sclerosis, NMOSD, even in myasthenia and inflammatory muscle disease. But now we have even maps for episodic headache, episodic migraine, and also chronic migraine. So my general question is how, what are the long-term effects, and is it cost effective in a developing country?
Let me ask the last question, easy for me to answer. I mean, it's cost effective in the sense if there is a significant morbidity for the patient, I mean, how can we decide whether it is a cost effective? It's unfortunately, our economy may not be affording to give it to everyone. But those who can afford, that is probably one of the options. There is no other options that are available at this time. I'm sure that you probably tried multiple other medications before. Even here in the US, the cost is a major determinant to whether we can give the monoclonal antibodies or not. For me to give a monoclonal antibodies, I mean, it's almost 3 to 5 times more expensive than in India, whatever that is available. And it costs close to about $100,000 to $150,000 per year for a patient. So the insurance companies, and not only that, it is our responsibility to select patients, try all the other modalities before we attempting the monoclonal antibodies. I'm sure in the near future, probably not that long, in next 10 years, the way that is that the field is developing, there are multiple competitive drugs, and not only that, we are seeing the bioequivalents. The bioequivalents are the similar kind of that, same physiology, same molecule, but it's a modified molecule. So those are available. So for example, infliximab has now at least 3 or 4 bioequivalents available. Since then, the cost is coming down. So once these drugs are flooding the market, slowly will cost can be reduced. Then the first question is long-term side effects. We have treated these with the MABs, that means monoclonal antibody, that completely humanized antibodies. We have been treating them for the last 10 to 15 years. In my office, I've been treated with even the ZMAB, which is infliximab, which is partially humanized. I've been treating them, at least I have 20 patients that in the last 15 years. I have seen only one patient developing serum sickness because of the immune complex disorder. Otherwise, everybody is responsible. Only problem with the ZMABs is we are developing antibodies against these monoclonal antibodies. So after a while, we're developing antibodies against the infliximab, which is not working properly. So then we have to change it. Now we have available the more humanized complete humanized monoclonal antibodies. And also we are seeing the other T cell treatment that we talked about it. That's a homogeneous T cell. You take the patient T cells, modify it, attach the monoclonal antibodies and giving. So the technology is changing. Again, the economic situation and the economical situation is one of the things that can control the spread of this, these treatments, unfortunately.
Thank you.
Yeah. Thank you very much, Dr. Suresh Anne. Ramohan, Dr. Ram Kairam, do you want to say anything?
I think he left, sir.
I think he has left. Okay, no problem. If there is no one, I wish to thank Dr. Suresh Anne for his very exemplary presentation, as well as answering all the questions, not only towards this monoclonal antibodies, but also in relation to the vaccine that we have started taking. Thank you very much, sir. So nice of you. And I request you to continue participating and give your expertise in the weeks to come also. And until the next week we'll have another speaker. Till that time, I wish you all the very best. And thank you and bye-bye.
Thank you very much, Sudhakar sir, and thank you everybody. Hopefully I will try to wake up early and see most of the meetings, and thank you for the invitation.